Hi, I'm Dr. Brian Kaufman, a retired family doctor, a CLL patient myself, co-founder, executive vice president, and chief medical officer of the CLL Society. Jake?
I am Jake Soumerai. I am a clinical investigator in CLL and assistant professor at Mass General Cancer Center and Harvard Medical School.
So Dr. Soumerai, there's been a lot of research done on combinations to help CLL and what the right combination is, how long the therapy should be given, when it should be started or stopped. You've done some research on a trial called the Bovin trial, looking at those issues and using measurable or MRD status to help guide that. Could you just remind us what the Bovin trial is and what exactly you looked at? Because I thought it was pretty innovative analysis of that data.
Of course, thank you. Thank you for the question. So the Bovin trial was a study that I conducted with Dr. Andrew Zelenitz at Sloan Kettering. And this includes 3 drugs which are highly active in CLL. It's based on really this backbone of Venetoclax Obinutuzumab. This is a standard frontline option for people with newly diagnosed CLL that we know achieves durable, undetectable MRD or measurable residual disease responses with just 1 year of therapy. And Zanubrutinib, we know it's a second generation or a sort of a new BTK inhibitor, similar in its mechanism to Ibrutinib, which I think many of us are familiar with, but has a favorable safety profile. What does that mean? It means that in a randomized study, when these have been compared head to head in people with relapsed CLL, we saw less of some of the key side effects like atrial fibrillation with Zanubrutinib as opposed to Ibrutinib. And so we proposed in the study that the combination of Zanubrutinib plus Venetoclax and Obinutuzumab, we call this Bovin, would achieve more frequent undetectable MRD responses, and that these would be durable. But something that's I think particularly notable about CLL is that, as you know, there's really a need to personalize therapy for our patients. I tell all of my patients that it can seem like no 2 patients are alike, right? I can see 20 patients in a clinic day, and they can all have vastly different clinical presentations, responses to therapies, histories, stories, and
so what we say is, if CLL patient, one CLL patient.
Yeah, exactly. And because each CLL disease behaves so differently, how one person's CLL responds to a given therapy might be very different from somebody else's CLL. And so why do all patients with VO, or for this matter, even the Bovin regimen, require a single duration of therapy? Why don't we adjust therapy based on some sort of variable, something that we see or something we know about the person? And so in this study, we use this MRD, or this measurable residual disease marker, to guide the duration of therapy. So the idea is that patients who achieved undetectable MRD in both the blood and confirmed in the bone marrow stopped therapy after as little as 8 months of treatment. And this includes a 2-month lead-in without Venetoclax, with Zanubrutinib and Obinutuzumab. The idea there was that we could maybe reduce the CLL to the point that it made Venetoclax easier to initiate, and this is indeed what we saw. What were the key findings? The primary objective here, the lead goal here, was to see if we could achieve more undetectable MRD responses than we had historically seen with similar combinations. And what we found was that the primary objective was met. We found that 89% of patients achieved undetectable MRD in both the blood and the bone marrow. And all of these patients, all 89% of these patients, did ultimately meet the criteria to stop therapy, and they stopped therapy after a median of just 10 months on treatment. And we've now followed these patients. We followed these people out beyond 2 years on average, including 15 months from the end of therapy. So this is actually a pretty good amount of follow-up after treatment is stopped to get a sense for what happens after we stop. and 94% of patients have remained undetectable with this average of 15 months off therapy. One did actually develop recurrent detectable MRD. This happened about a year after stopping therapy, and this person was able to re-achieve undetectable MRD when we resumed the Venetoclax and Zanubrutinib without the antibody drug. Other questions obviously come up. Is it safe? Is this well tolerated by patients? And we did find that this was a well tolerated combination. The thing that we have seen with other Venetoclax and BTK inhibitor combinations has been a risk of grade 3 or worse, which means more severe neutropenia. These are the infection fighting white blood cells. We like them to be higher to fight infection. We don't want them to go too low. And this is something we've seen with other combinations similar to this. And in this study, we found that just 18%, so less than 1 in 5 patients on the study developed grade 3 or worse or severe neutropenia. And this tended to be transient.
Low neutrophil count we're talking about here, right?
That's right, low neutrophil count. And this compares favorably to what we've seen with other similar combinations, where we've seen this occur in as many as 1 in 3 to 1 in 2 patients that have received other similar therapies. But the thing that this is a highly effective regimen. Obviously, this requires additional patients to be treated on this regimen to really better understand just how high the rates of MRD response are, and confirm that this is this safe in a larger group of people. But something that I think was really exciting about the data was something we found with the science that was done with the samples that were collected. So we did something where we studied the kinetics or the speed of the MRD response. So this is looking at the level of CLL in the blood before treatment, and then looking 4 months into treatment. This is just 1 month after Venetoclax hits that target dose that we want it to be at. And what we did was we looked at the change in MRD, meaning what is the delta? How much do we see that CLL has reduced in the first 4 months? And does this predict treatment outcomes? Does it predict, for example, the likelihood of achieving an undetectable or clear bone marrow within within 8 months? But also, does it predict post-treatment outcomes? Meaning, we stop therapy in all patients. Does the speed of response potentially predict how we do after we stop therapy? And really, at the end of the day, what we're asking is it not just that you achieve undetectable MRD, but is it also how quickly you do so that ultimately predicts outcomes? And these were actually very interesting data. What we found was that patients who achieved rapid kinetics, meaning that they had a greater than 400-fold reduction in their CLL over the first 4 months, this happened in 6 out of 10 patients on study, that these people, all of those patients who achieved that, went on to achieve undetectable MRD within 8 months of treatment. But even more encouraging is that when we stopped therapy, that these people were more likely to remain undetectable for longer. And so the probability of having very, very low levels of MRD recurrence below even the level that we saw in the test that was used as the primary tool on the study was higher if you had a slower reduction in your CLL level in the first 4 months.
Let me ask you about that, because we do have some sophisticated patients there. And in the paper, you use 2 methods to measure the residual disease. One was flow cytometry, which is the standard method, 1 in 10,000 cells. But you also used immune sequencing. Is there anything you want to share with patients about what your findings were and the reasons for these 2 different methods, and explain a little bit about the difference of those 2 methods?
That's a great question. So these are, we can measure MRD using very different methods. Flow cytometry is at the time that this study was started, was the only clinically validated, the only tool that we were actually at the time supposed to be using to make treatment decisions. Actually, since then, this other test called clonoSEQ, which actually effectively measures basically specific fingerprints of the CLL before treatment, then looks for those same fingerprints once you start therapy, and is able to detect them in even at a lower level of MRD, down to 1 in a million cells, if you have enough sample. This has since been an approved assay or an approved test for people with CLL. And this is the tool that was used for the studies that looked at MRD kinetics. In our study, we did look at how they match up. So if you are undetectable with a flow cytometry test, are you also likely to be undetectable with a clonoSEQ test? It turns out they're actually they both are very good. They both, down to a certain limit of sensitivity, they match up pretty well. So if you're undetectable with one at a certain level, you're likely to be undetectable with the other at the same level. They also both are similar in terms of how well they predict being undetectable in the bone marrow. So most of the time, about 85 to 90% of the time, if you're undetectable in the blood, you are also undetectable in the bone marrow. And this is true with both assays. The potential advantages of the clonoSEQ test is that it can be done anywhere. You don't need to have specialized flow cytometry pathologists who do this, because it gets sent out to one place. But also it can go down to a lower level, meaning that unlike flow cytometry, where I can only reliably say that somebody has no measurable residual disease at a level of 1 in 100, 1 in 10,000 cells, with the clonoSEQ test, you can go down to 1 in 100,000 cells, or even 1 in a million cells. So it's potentially has some advantages there. Although we need to learn more about what this means, right? Is it better to get to a deeper level of an undetectable measurable residual disease with each specific therapy? And what does this mean in terms of the long-term responses and outcomes for people?
Dr. Soumerai, this is so interesting, so exciting. Is there any final thoughts or any direction you're looking to take this research that patients should know about?
Yeah, so I mean, we're very excited by the MRD kinetics, or this delta MRD 400 finding, and so we're actually planning to validate this prospectively, meaning to develop we have a new study in development where we're going to take patients who receive the bovine therapy and measure MRD 400 and use this to guide duration of therapy. We like this for a couple of reasons. One that I'm sure patients will like, which is that this is something that we measure in the peripheral blood. So if we can skip all these bone marrows, I think that's good for everybody. But the other thing is that potentially by identifying patients who might need longer therapy or might benefit from the addition of another agent early, maybe we can catch patients who need more sooner and intervene at an earlier time point. And maybe this could actually help advance the care of people with CLL even beyond what we can do with just a static measurement, right? Get X months of therapy, check for MRD, undetectable or not. Maybe we can do more using this really dynamic assessment of MRD early on therapy.
I am so grateful for what you're doing. This sounds very exciting, and let us know when that other trial opens. Thanks so much.
Thank you very much.